Good day. I am Dr. Abigail Andal, and I am tasked to discuss on evidence-based decision-making on therapy, particularly the appraisal of randomized controlled trials. I declare no conflict of interest in the conduct of this lecture. The objectives of my presentation are as follows. There are different critical appraisal forms for therapy depending on type of study. The type of study with highest validity for questions on therapy are systematic reviews, followed by randomized controlled trials or RCTs. For this session, we will focus on appraisal of RCTs. As a review, clinical questions for therapy are usually phrased following this syntax. Among P, patients with a certain disease, how effective is I, a certain treatment, in preventing O, an adverse outcome? Methodology could be added, and this could either be a systematic review or RCT. These are the general questions we need to answer. We will go through them one by one. First step is the assessment of relevance. In this step, we want to determine if the journal article could answer our clinical question. For this step, we only need to answer this question. Is the objective of the article comparing therapeutic interventions similar to your clinical dilemma? To determine this, we just need to compare the PICO of our clinical question with that of the journal article. If the answer to the question is yes, then we could continue the appraisal. Otherwise, we should look for another paper that will answer our clinical question. The next step is to appraise validity. At this stage, we wish to determine the truthfulness of the information in the paper. In other words, we want to know if we could believe the data presented in the article. In answering questions under validity, we should look into the methodology section. There are two sets of questions, which are the primary and secondary validity guides. The following are the primary validity guides. Each question will be discussed separately. These are the secondary validity guides. Let us now discuss how to answer the primary validity guide questions. First, we must determine the presence or absence of randomization. Randomization is important in questions on therapy since this process ensures that the groups are truly comparable by distributing prognostic factors equally between groups. In addition, allocation concealment should also be done to eliminate bias from clinicians and researchers. To answer this question, check the methodology for words like randomization, randomized, or randomly allocated are assigned. If these were mentioned and discussed adequately, then we could answer yes for this question. The second question under primary validity guide has two sub-questions under it. The first sub-question is regarding completeness of follow-up. To answer this, we need to know the dropout rate of the study. If substantial, it would lead to questionable validity of the conclusions. In general, a dropout rate of greater than or equal to 20% is substantial. If dropout rate is less than 20%, we could determine if the number of dropouts affected the results by determining if the authors did an intention to treat or IDT analysis. IDT is a statistical analysis that maintains prognostic balance generated from the original random treatment allocation. If the study did not do IDT, we should do best case and worst case scenario. If the conclusions remain unchanged after applying the IDT or doing best case worst case scenario, then the dropout rate is not substantial, and the follow-up could be considered as complete. In order to answer the first sub-question, we need to check number of patients enrolled at the outset and compare this with the number of patients reported in the results table, and check whether an ITT analysis was done. The second sub-question is, were patients analyzed in the groups to which they were randomized? We need to determine if all those belonging to the control group or treatment group are analyzed from beginning to end in the same grouping. This is essentially what an ITT analysis do. Thus, if it was done in the article, we could answer yes for this question. Additionally, we could look in the methodology section for any crossing over treatment modalities done. If there are, then the answer for this question is no. To answer the second sub-question, we just look for the following in the methodology section: ITT analysis and presence or absence of crossing over treatment modalities. We now go into the secondary validity guides. The first question is regarding blinding. Blinding is concealment of intervention. This is done to avoid bias from patients, clinicians, and study personnel. However, blinding is not always possible for patients and clinicians, such as when the intervention is a surgical procedure. In these situations, we should check if outcome events were assessed by investigator committees who are blinded or are not directly involved in the trial. To answer this question, we should look in the methodology for the use of identical preparations. If blinding is not possible, the process of how treatment assignment was withheld from outcome assessors should be mentioned in the study. Another secondary validity question is, were the groups similar at the start of the trial? Treatment and control groups should be similar at baseline for all factors that determine clinical outcomes. If the control and experimental group are similar at baseline, the results or differences between the two groups could be attributed to the intervention alone. To answer this question, we should look at comparison of baseline characteristics usually seen in Table 1. P-value should be more than 0.05. Even if there is no statistical difference between control and treatment group, we should still assess whether the magnitude of differences are clinically important. Last question under secondary validity guide is, aside from the experimental intervention, were the groups treated equally? To answer in the affirmative, there should be no co-intervention done in the study that may distort the result. To answer the general question whether the article is valid or not, we need to decide if the flaws we identified are significant enough to threaten the credibility of the results. If this is the case, we'll need to look for another study. Simple rule to guide decision-making is, the article should answer yes to at least one primary guide and two secondary validity guides. Let us now go to the appraisal of the results. The first question is about magnitude of treatment effect. Before we could answer this, we need to understand the two types of outcomes, dichotomous and continuous. Dichotomous outcomes are those with only two results. Within each group, they are usually presented as proportions. Measure of effectiveness could be expressed as relative risk, absolute risk reduction, and relative risk reduction. On the other hand, summary of results for continuous outcomes are usually presented as means. Measure of effectiveness is expressed as mean difference between groups. This slide shows computation for relative risk. This is how we compute for absolute risk reduction, relative risk reduction, and number needed to treat. Aside from knowing how to compute for the measure of effectiveness, we need to be able to interpret the computed numbers. Relative risk, or RR, tells us if the treatment is harmful or beneficial. RR of less than 1 means the treatment is beneficial. RR of 1 means the treatment has no effect. And RR of greater than 1 means the treatment is harmful. Absolute risk reduction, or ARR, is the risk difference between control and treatment groups. ARR greater than 0 means the treatment is beneficial. ARR of 0 means the treatment has no effect. And an ARR of less than 0 means that treatment is harmful. Relative risk reduction, or RRR, tells us how much a treatment decreased risk of disease. It is the most useful way of expressing effectiveness. RRR greater than 0 means that the treatment is beneficial. RRR of 0 means the treatment has no effect. And an RRR of less than 0 means the treatment is harmful. Number needed to treat, or NNT, tells us the number of patients we need to treat in order to see one patient have the beneficial effect. An effective treatment will have NNT that is closer to 1. Second question under appraisal of results is regarding precision of treatment effect. Precision will be checked by looking at the confidence intervals, or CI. The closer the values, the more precise the estimates. More importantly, the CI should be either both on the side of benefit or both on the side of harm to determine if treatment is definitely beneficial or harmful, respectively. If the ends of the CI are on the opposite sides, then either the study is inconclusive or the two treatments are equivalent. Another way to determine precision is to check for the p-value. A p-value of less than or equal to 0.1 is acceptable. A cut-off p-value of less than or equal to 0.05 is better. The fourth step in the appraisal is the determination if the results of the study could be used for patient care. The first question is regarding the applicability of the results to the patient. To answer this, we need to see if the patient in our clinical scenario has no significant difference from the study population of the article by looking at the inclusion and exclusion criteria. If there is no compelling difference, we could answer yes for this question. Outcomes measured in the study is the next consideration. Important outcomes are those related to mortality and morbidity, but sometimes these are hard to assess since they may require long periods of follow-up. Thus, some researchers use surrogate outcomes, which are physiologic measures. Reductions in these laboratory parameters does not always translate in the decrease in morbidity and mortality. A classic example of this is the drug clofibrate. It was shown to decrease serum cholesterol but was shown to increase all-cause mortality. Consequently, for RCTs, it is important to note if there are reports regarding morbidity, mortality, adverse events in the article. Next question for this step is, are the likely treatment benefits worth the potential harm and costs? We need to know the harms and price of the treatment and to balance this with the benefit to be gained by the patient. Last step in the appraisal is the resolution of the clinical problem. It is acceptable for physicians to make decisions for patients regarding treatment if benefits far outweighs the harm and cost is not a problem. Otherwise, we need to explain the results of the study in an understandable way to the patient so that he or she could decide for him or herself. Let us now go through a sample appraisal of an RCT. This is the clinical case scenario from which we got a clinical question. Our clinical question is, among adult patients with stage 2 hypertension, how effective is olmesartan in comparison with losartan in controlling blood pressure using randomized controlled trial? Search for PubMed yielded the following article, which was published last 2012. For relevance, we compare the PICO of our clinical question and the journal article. They were similar, so our answer for this question is yes. We will now appraise the validity of the article. We answered yes for the first question since randomization was stated in the methodology section as seen in the quoted text. For the second question, the computed dropout was 9.67%. To determine if this was substantial, we checked if ITT analysis was done, but the paper did not mention doing it. Thus, we did a best case, worst case scenario using values from the journal. Both scenarios showed benefit in favor of the experimental group. Therefore, dropouts did not significantly affect the results of the study, and follow-up could be considered complete. This is the best case, worst case scenario done based on the data from the article. For the second sub-question, we answered yes, since there was no crossing over modalities done. Blinding was done for this study as stated in the quoted text. To answer the question regarding similarity of the groups at the start of the trial, we checked Table 1, which shows the baseline demographics of the patients. P-value for all factors was greater than 0.05. Furthermore, when looking at the correct characteristics of both groups, there was no note of any clinically significant difference that may affect the outcome of the study. Hence, we answered yes to this question. There were no co-interventions done in this study, so the answer to this question is also yes. The article answered yes on all validity questions. Therefore, overall, it is valid. Let us now go to the results of the study. For the question on magnitude of treatment effect, we focus on our outcome of interest, which is control of BP for those with hypertension stage 2. These are the completed RR, RRR, ARR, and NNT. The following values could be interpreted as follows. Olmesartan is beneficial. Olmesartan reduces the risk of uncontrolled BP by 15% compared to losartan. We need to treat 9 people for one of them to have controlled BP as a result of the treatment. In assessing precision, it was noted that p-value for the outcome of interest were all less than 0.05. We will now discuss if the results could be applied to the patient. For the first question, we answered yes, since a patient in our clinical scenario meets the inclusion criteria and none of the exclusion criteria of the study. Efficacy and safety were both assessed in the study. Thus, the article considered all clinically important outcomes. For this question, the quoted text emphasized that both the medications used in the trial were well tolerated. There were no serious adverse events nor mortality in the experimental group. Total cost of medication per month is 877 pesos. Considering that the patient is a teacher, we assume that the cost of medication is not that high in comparison to the benefit of having controlled blood pressure. We now go to the resolution of the problem. We will let the patient decide after explaining the findings of the study as follows, since cost of olmesartan is still higher than losartan. I would like to reiterate that this is just a sample appraisal of an RCT. Other more recent RCTs and systematic reviews may have already come out that might have different results regarding the clinical question. As stated in the beginning of the lecture, systematic review is a study design at the top of the hierarchy of evidence for therapy. Thank you for your kind attention.
The unique mechanism of action of Sanofi unique 4-strain combination of Bacillus clausii spores begins by ingesting the ampule containing billions of spores of Bacillus clausii. Unlike other probiotics, such as Saccharomyces boulardii and Lactobacillus rhamnosus GG, Sanofi unique 4-strain combination of Bacillus clausii spores resist the acidic pH within the stomach and stay intact. At reaching the small bowel, they germinate into their vegetative form, contributing to reduction of diarrhea. The bacilli adhere to the intestinal cells, allowing for mucosal colonization and forming a protective barrier known as a biofilm, which protects the intestinal epithelium from diarrhea-causing pathogenic bacteria. In addition, Sanofi unique 4-strain combination of Bacillus clausii spores produces clausin, a natural antibiotic which activates against gram-positive bacteria like Clostridium difficile and Staphylococcus aureus. Most of the other probiotics do not produce clausin. Sanofi unique 4-strain combination of Bacillus clausii spores resists common antibiotics and survives in the gut up to 14 days after treatment, as opposed to other probiotics which only remain for 5 days. Sanofi unique 4-strain combination of Bacillus clausii spores, prevention and treatment of dysbiosis and antibiotic-associated symptoms